So thank you all for coming along today to Daria. We have presenting Dr. Adam Bourne, who's going to be talking to us about the very relevant and interesting topic of chemsex. Just for a bit of background, Dr. Bourne is an Associate Professor of Public Health and Deputy Director of the Australian Research Centre in Sex, Health and Society at LaTrobe University, where he leads a large program of research relating to LGBTIQ health and well-being. And he's conducted a range of mixed method studies examining sexualised drug use in the UK, Europe and Southeast Asia, and partners on related projects with colleagues at UNSW here in Australia. So this is probably a topic that is very new and interesting, and so I'm really excited to present Dr. Adam Bourne to talk about this today.
Thank you so much, Chris, and thank you to you and the rest of the team for the invite to come along and address you this afternoon. I am by background a health psychologist, so my research is really from a social and behavioural health perspective. So a lot of what I'm talking about here today are the social, cultural, personal factors that shape and inform chemsex as a phenomenon. And in the latter half of the talk, I'll be talking a lot more specifically about harm reduction approaches in clinical and therapeutic contexts for people engaged in chemsex as well, just so you can kind of understand the flavour of the talk I'll be giving. So to kind of give you some placeholders or milestones of what I'll be talking through, I'll start with just and the kind of the meaning and the context of chemsex. It might be a familiar topic for some, but as a starting point, kind of trying to make some definitions. I'll summarize some key data sets that we have access to here in Australia around chemsex that give us a sense of the prevalence of the patterns that we observe within this phenomenon. And then talk a bit about the consequences and the harms associated with chemsex, as well as some of the motivations for engaging. A little bit around chemsex and sexual health, which has been a topic of really fierce debate and discussion. And then, as I said, some attention on harm reduction principles in the context of chemsex. So let's start at the start and what it is we mean by it and the context within which it occurs. So bear with me as I talk through a kind of few different dimensions of this. Chemsex is broadly understood as sex between men. I'll talk about other populations in just a moment. Sex between men that occurs under the influence of certain drugs, which I'll mention in a moment, taken immediately preceding or during the asexual session, specifically in order to facilitate sex. The really key dimension to consider and hold in mind here is the intention to use drugs for the purpose of sex. So I take this drug in order to facilitate a certain kind of sex that I want to have, rather than a coincidental kind of use. I had taken drugs and then I had sex. I just happened to be high at the point I had sex, rather than I was taking it for that specific purpose. So that's a kind of quite a key dimension and a key definition to hold in mind in relation to chemsex. There's a lot of discussion and debate within the literature around which drugs are most commonly associated with chemsex. You will find some dissension, but what you tend to find is that these four drugs are very commonly associated with the chemsex scene. So mephedrone, a synthetic cathinone, which is much more commonplace in the UK and in parts of Western Europe, far, far less commonly here in Australia. GHB or GBL, and I think I saw a talk from Jack Freestone to Daria a couple of months back, specifically around GHB and GBL. Crystal methamphetamine being very definitely the most commonly utilized drug in the sphere of chemsex here in Australia, and also ketamine as well. Again, ketamine kind of more or less common in the chemsex scene, depending on not just the country that you're living in, but even the city to some extent, and the availability in the drug markets and how those shape drug practices. Each drug can, the delivery mechanisms of the drug can vary. certainly here in Australia, more commonly for men to be smoking crystal methamphetamine as part of the ChemSex rather than injecting, but there are some variants to that, and depending on your locality or depending upon some of your personal characteristics, which I'll talk about more in a moment. So the context of ChemSex, as I said, it's predominantly among men who have sex with men, gay, bisexual, or other men who have sex with men, with some exceptions, which I'll talk about in a second. It more commonly occurs in private homes, although it is a practice that can occur in sex on premises venues such as saunas or bathhouses as well. It's associated more so with group sex activities, and it's associated with sexual longevity. So men having sex for longer periods of time under the influence of drugs, particularly stimulant drugs that allow them to stay awake and stay sexually active for long periods. And as a consequence of that, like longevity, it can be associated with high partner turnover as well. So not just across the year, but also within the same sexual session. So perhaps men using drugs in a fixed location and a range of partners coming in and out during, a 1 day, 2 day, 3 day long period, depending, how many drugs are and of what form are being taken. There are some indications of a transaction. There's some evidence of transactional sex occurring in relation to chemsex. We see this particularly in relation to older men facilitating access to more expensive drugs, particularly in some contexts, crystal methamphetamine, depending on the price point, and sex in exchange or a transaction for drugs. And we see overall that men who engage in transactional sex or in paid sex work are more likely to be utilizing drugs associated with chemsex, particularly those 4 that I mentioned. We see that the access and uptake for chemsex is facilitated a lot via GPS facilitated sexual networking apps. So things like Grindr, like Scruff, like Hornet or Jacked, depending on, again, on the context, the country that you're living in, or even the cultural group that you're a part of, men can use different kinds of applications to facilitate that kind of sex. As I said, a lot of it is happening in private homes facilitated by those apps, but there is still a significant role for saunas or other sex on premises venues. And that's true here in Australia as it is in many other countries. As I mentioned, it's more commonly associated with smoking, like as in smoking crystal methamphetamine, for example, but it can include injection as well. And the common term utilized among gay men in relation to injecting drug practices is slamming. And there's an interesting sociological discussion around why that particular term is utilized, and some suggestion that it's used as a way of kind of distinguishing or differentiating from other forms of sex, of drug users, injection drug users, and a way of distancing oneself from what can be quite stigmatized practices of injection drug use, particularly among opiate users. So that's the kind of broad context of chemsex. The terms that are often used among professionals, like ourselves in research or in practice, are chemsex. Party and play is another very common term, or P&P, or sexualized drug use is a more descriptive term. Within the kind of broader vernacular used by gay men, you'll see a range of other terms, men who are high and horny, men looking for M play, for mephedrone play, for T play, or Tina or crystal methamphetamine, chem play, wired play, men who are chilling. These are lots of terms that you can see utilized in online environments as a way of signifying the kinds of sex that men are looking for. And again, a range of other kind of shorthand terms, the ice crystal sign being commonly utilized, the diamond sign also being utilized in relation to signify use or interest in using crystal methamphetamine in online environments as well. Chemsex is, in some respects, an age-old phenomenon. The idea of people utilizing drugs or substances, including alcohol, during sex is not a new phenomenon necessarily. But perhaps I think what we've observed in the last 10 years is changing circumstances of such drug use and the kinds of drugs that people are using. So the use of alcohol, for example, or even cannabis in a sexual context facilitates a very different kind of sex than can be the case for crystal methamphetamine. Crystal meth can make you feel aroused. It can have all the kinds of effects that a stimulant can do in raising your heart rate, your blood pressure, inducing feelings of euphoria, but can also have this really important additional effect of a very, very intense sexual arousal. And that hasn't been the case in many drugs that have been popular on the gay scene or in many other scenes for a long time before that. Cocaine, ecstasy, for example, don't have those kinds of additional outcomes or kind of drug effects. So I guess I say all of that is to just kind of acknowledge that there are a variety of forms of chemically induced or facilitated sex that have existed for a long time across a range of populations. But if we're thinking about just that use of particularly sexually enhancing or sexually arousing drugs, we do tend to see it very, very much clustered among men who have sex with men. There's only been a handful of other studies that have been conducted on different populations. A recent example came last year from a study of heterosexual HIV and HIV positive and negative clients at sexual health clinics in England, where they observed very, very low rates of engagement in chemsex within the previous 12 months. In the previous 3 months, which were almost zero among HIV positive men and women, and only 1% reporting use of any kind of chemsex drug among HIV negative heterosexual men and 0.2% among HIV negative heterosexual women. So it does exist, but at a very, very, very low level. Matthew Hibbert, as part of his PhD back in 2019, also does a study among women who have sex with women, so predominantly lesbian, bisexual identifying women. And he observed that in a large online community sample, about 3% of women who have sex with women had used ketamine, methadone, GHB, or GBL in the previous 12 months, but wasn't necessarily able to tie that at the event level to whether or not that use was happening in a sexual context. None of the women had utilized crystal methamphetamine, but actually 14% were talking about how they'd use cannabis to facilitate sex. Which kind of speaks to a broader complexity we have in this space of defining exactly which drugs fall into the umbrella of chemsex. And again, as I said, that can vary in different countries. Some will include poppers or amyl or alkyl nitrites as part of the definition, and some won't, but that will have have a really, really big impact upon how we estimate the prevalence of chemsex. I guess if we just to kind of summarize that, the key things to consider is that it's more common, considerably more so, among men who have sex with men, which you'll see in just a second, and more commonly associated. Like the key issue of concern relates to the sexual arousing dimension and the intentionality of drug use, which is what distinguishes it from previous forms of chemically facilitated sex. If we think about the prevalence and the patterns of chemsex, there are 3 key surveys or data sets we can look to inform our understanding. One is the Gay Community Periodic Survey, which is a survey conducted of gay and bisexual men or other men who have sex with men at Pride events that happen all across Australia on an annual basis, typically around about 3,000 people each time. There's Flux, Following Lives Undergoing Change, which is a large online cohort survey of gay men that's specifically designed to track use over time. Just over 3,000 people recruited at baseline. And then there's HIV Futures, a periodic online survey of people living with HIV, typically around about 1,000 people, of whom about 800 or so are men who have sex with men. So the first of these, the Gay Community Periodic Survey, this is an analysis that was done a couple of years ago, but we haven't, as far as I'm aware, we haven't observed much difference in this kind of trend line in the more recent years. What you see here is in the blue line, any use of crystal methamphetamine as the drug of particular choice in the chemsex scene here in Australia. All use in the gray line is among HIV negative men, and in the orange line is among HIV positive men. So straight off the bat, you see that about 11.4% had used crystal meth within in 2014, the most recent time it was surveyed, had used crystal meth at any point in the preceding 6-month period. That is considerably higher, 27.4% among men who were living with diagnosed HIV. You look at the Following Lives Undergoing Change study, or Flux. Here, you have a whole range of drugs utilized within the previous 6 months. Excuse me. So it's ever used or used within the previous, ever used in the blue bar, used within the last 6 months in the green bar. And here you see crystal methamphetamine. So about 1 in 3 men had ever used crystal meth. About 14% had done so in the previous 6 months. And a pretty small percentage, a reasonably small proportion, 4.5%, had injected within the previous 6 months. Just to kind of reinforce the point I was making around how it's associated with group sex activities and with a higher number of sexual partners. Here you see from data from Flux, which looks at crystal meth and sexual behavior. In the green bar, it's group sex with casual partners, and in the gray bar is sex with more than 10 partners in the previous 6 months. And you see on the far right-hand side, the cluster of bars among those who had recently engaged in crystal meth use. We see a much, much higher proportion of those engaging in group sex and with a higher number of sexual partners, which just increases the exposure, particularly to STIs, which is something that I'll mention again in a moment. And finally, the third data set, the HIV Futures Survey, Health and Wellbeing of People Living with HIV in Australia. This was an analysis done in 2018 that looked at drugs associated with ChemSex among the sample of 714 men at that time. You see 5.3% had used any of the drugs on a regular basis, and 22% overall had used crystal meth at some point. And of those, a much larger proportion, 79%, were smoking, although a pretty sizable proportion, 56%, said that they had injected crystal methamphetamine. So in a kind of the associations become quite clear in looking through those data quite quickly. It's much more commonly the case we observe chemsex among men living with diagnosed HIV. It's between 2 to 5 times more likely, depending on the way in which you ask the question and the context in which you do so. It's much more common among men living in gay urban centres, so particularly in the Australian context, Melbourne and Sydney, but in Europe, London, Barcelona, Amsterdam, Berlin to some extent, all fall out as kind of major concentrations of chemsex. In Southeast Asia, Thailand very much stands out far and away above any other Southeast Asian city as an area where we tend to see a big concentration in chemsex practice. And it's more common among those who sell sex, so between 1.5 and 2 times more likely to be engaging in chemsex. There's there is some variation by age. And crystal meth use typically slightly more common among men aged 40 and above. Again, I wish I could tell you this is always clear cut. It's not. You do see it across the spectrum, but most Australian data would suggest it's more common among those aged between about 40 and 50. And what becomes quite obvious quite quickly in talking through those data, I imagine, is just about the challenges in the measurement and the monitoring of chemsex. So the case definition, which exact drugs are we talking about? That can vary from one study to another. We try to maintain a focus on those 4 particular drugs I mentioned at the start. The time period of analysis, are we talking about drug use in the last 12 months, 6 months, or 3 months, varies a lot between these kinds of surveys, which makes it kind of challenging, and the setting within which the drug use is occurring. And what we're grappling with a lot is studies that are broadly global association studies. So they're measuring the use of drugs, they're measuring sexual behavior and sexual practice, and we're just broadly understanding, is there an association between these two? What we have far less of are event level data, which tell us about, was this drug used in this sexual context? And that to some extent is limiting our ability to have precision around the prevalence of chemsex practice. So that's why some of my kind of summaries become a little bit vague, because this is still an emerging literature and we don't have that specificity in event level data in most contexts, in fact, really in any context yet. You get vastly different findings depending on the sampling method, which is not surprising to people working in the drugs field. I know there was a lot of concern raised when clinic-based samples are published, which have shown prevalence of chemsex among clinic samples of up to 50 or 60%. If you're looking at something like 56 Dean Street in central London, and that caused a lot of alarm in the media when that figure was published. But it's considerably lower when you're looking at community samples, online samples in particular, where you tend to see reported rates being much closer to the kind of 5, 10, 12% kind of basis, certainly within the last 6 months. Just as an example of how the way in which you ask the question can also massively influence the indicated prevalence of chemsex. This was a paper published by Kathleen Ryan and colleagues at the Bourne a couple of years ago, which was comparing answers to questions asked in 2 different surveys that they had. One was, in the last 6 months, how often have you used party drugs for the purpose of sex? Weekly, monthly, once, a few times, or never. When asked the question that way around, 16.9% said that they used them weekly, monthly, once, or a few times. When asked in the past 6 months, which of the following substances have you used before or during sex? Alcohol, amyl nitrate, methamphetamine, cannabis, cocaine, ecstasy, etc., etc. When asked that way around, you end up with a figure of 54%. So you can see very quickly the challenge we have in that case definition and exactly which drugs we're concerned about in this context. And as I said, some quite fierce discussion and debate in the literature about what should and shouldn't be included. Population level, more harm associated with alcohol use. In relation to acute mental health related harms, or perhaps sexual health related harms, crystal methamphetamine far away the drug of most concern. So how and where we place emphasis is an ongoing issue of contentious debate, I would say. In summarizing that as best I can, with all of that uncertainty, as I said, population prevalence of chemsex among men who have sex with men, somewhere in the region between about 5 to 12% regular use. More common among men living with diagnosed HIV, can vary considerably by city of residence. Melbourne and Sydney very much centres of chemsex practice. Here in Australia, perhaps unsurprisingly, given concentrations of gay men in these areas. Injection of chemsex is prevalent, but less common than other modes of administration. So, okay, that's the context and that's the patterns and the prevalence. So why? Why do people engage in chemsex? What are some of the motivations for doing so? We wrote a paper on this a couple of years ago based on a qualitative sample that we recruited back in the UK, in very, very similar findings and other studies that have been done here in Australia. And they kind of some of the motivations fall into 2 camps. There are the motivations that are about really fundamentally about trying to overcome something. There's a challenge that people are experiencing and they're using drugs to help overcome that kind of challenge or issue of concern. The second group clusters together as these are things that I value, that I can further advance, or I can get more of, I can facilitate more of by the use of drugs. So for example, increasing arousal and restoring libido. This is particularly common finding among men who were HIV positive and some who are a bit older. And this guy talking about how he doesn't have a sex drive anymore. It's very heavily impacted the point of his diagnosis, but slamming, injecting crystal meth for him helps him to still get horny. Other men talking about how it can increase sexual confidence. This guy saying, I think when I was using drugs, I didn't have body issues. I didn't think, am I feeling too fat, or feeling that I didn't really feel that attractive. I'd have sex with people I wouldn't feel like I'd feel like I was having sex normally. So increasing sexual confidence, a really common reported finding. It's not just those overcoming kind of pathologies, I suppose, that was the case. It's also that people want to use them to advance the things that they particularly value. This guy, I love, this is a quote I've used an awful lot over the years. This guy describing sex on mephedrome, it was the best sex I'd ever had. I used to say it was like the heavens opened, the light came down when I had an orgasm, because it was that intense. It really was. I've never experienced that sober. Sounds pretty fun. And in the Flux study, when asked in a survey to indicate their rationales or motivations for using chems, a very broad range of answers. But actually, if you see along the bottom, more than 70% for fun, or to get a buzz, the most commonly stated reasons for using crystal methamphetamine. A lot of the time, the media discourse around this, or the community discourse, has been gay men using drugs because they have low self-esteem, because they're concerned about internalized HIV stigma, internalized homonegativity, challenges in achieving intimacy. We tended to pathologize use an awful lot and pathologize the reasons for use. In fact, most of the stated reasons are quite different and much more affirming in nature. And that's really important, I think, to hold in mind in a clinical context. And I guess I'll just say quickly on this, we often have a sense that chemsex can be very mechanical, very transactional, and kind of devoid of that kind of sexual connection and chemistry or intimacy, given the large number of partners and the large turnover of partners that I was talking about earlier. In fact, I won't go into all the ins and outs of the analysis that we did here, but in a study we did among people living with HIV from the HIV Futures survey, we actually observed that compared to people who didn't engage in chemsex, those who occasionally or regularly engaged in chemsex reported higher levels of resilience, lower levels of HIV-related stigma, spent more time with friends in the LGBTIQ community, spent more time with other people living with HIV, and reported higher levels of support from people living with HIV or other LGBTQ friends. And these are association level data, but they just kind of tell us a slightly interesting story that counters a lot of the dominant narrative around the kind of sex that people are having, and actually reinforces some qualitative literature that talks about what can be quite an intimate encounter that people are having, particularly if they're able to dose at the same rate and the same level. So they're both reaching those points of ecstasy where the light comes down and it's this most amazing organism that person was talking about. They can reach those points together. This can actually be a very, very intimate experience. So again, just kind of important dimension to hold in mind. It's not all great. It's not all fun and intense orgasms, though. And speaking to an audience of drug experts, I don't need to perhaps labor the point around some of the consequences and harms that men are exposed to. In the Flux study, we asked a relatively blunt, subjective, single-item question about whether or not people felt that their use of drugs in the last 6 months had been problematic. I think the wording was something like, has it had a negative impact on your everyday life, or have you become concerned about your drug use? Overall, 15.7% considered their use to be problematic, about 1 in 7. That was considerably higher among those who were using crystal methamphetamine, 44.1%, feeling that their use had become problematic and indicating a kind of support need. There, again, a range of positive outcomes of using crystal meth for people in the Flux study. Having better sex, having some great parties, gaining more confidence, but also a range of things that they were concerned about and negative consequences associated with crystal meth use, accidental self-injury, leading to the breakup of families, of friendships and problems with families or with partners, and people reporting having unsafe sex in whatever form that made sense to them, depending on which modality of safer sex that they were more commonly utilizing, if that was condoms, if that was PrEP, if they had an undetectable load, but however they interpreted unsafe sex, and to mean they felt that they were having more of that under the influence of crystal meth. I think Jack, in his talk he did a couple of months ago, talked in a bit more detail about gamma hydroxybutyrate or gamma butyrolactone, GHB or GBL. For anyone who isn't familiar with it, it's a central nervous system depressant. It can induce euphoria and relaxation and increase libido, but it's also has to be dosed very, very carefully. It's incredibly easy to overdose on GHB, and quite a number of countries have seen a large increase in GHB-related adverse events, emergency admissions and deaths. Between 2011 and 2015, the UK reported 117% increase in the number of GHB-related deaths by overdose, and the vast majority of whom we understand to be gay and bisexual men. And that experience of overdose isn't mirrored to the same extent here in Australia, partly because GHB hasn't reached the same level of popularity, maybe yet, there's certainly signs from talking to practitioners on the ground that they are observing an increase in GHB related practice, but obviously research is always a year or so behind documenting said practices. Certainly in the Flux study, in the last 19.6% said that they had ever used GHB, 2.7% were doing so monthly, and 5.4% less than monthly. Those men who were using it, again, more likely to be HIV positive, more likely to have a high number of sex partners, more likely to engage in group sex, and actually more likely to be more connected to people within the LGBT community, which is important for a range of reasons I'll come to towards the end. What's concerning is the extent and the overdose that we observed within that sample. Of those who are using GHB at least monthly, 28.7% said that they had overdosed at least once, and 21.8% said that they'd overdosed more than once during that period. And this is, an issue I think for us to be very, very attentive to in how we educate men around safe dosing practices in relation to GHB and what they might need to do in an emergency situation to kind of mitigate the risk to life to individuals who utilize G. When asked about some of the consequences of GHB within the Flux survey, this is reported proportions of people who needed medical attention, had to attend a hospital emergency department, who had hurt themselves or who had become sick as a consequence of using GHB. Although, just to kind of reinforce the same point again, I suppose, still a very large proportion talking about having had better sex in the context of GHB use as well. So it's always just acknowledging that balance that men are trying to strike between the possibilities for pleasurable sexual encounters alongside the risks and the very real risks and the very real harms that some have been experiencing. I don't want to talk at great length around sexual health. Unsurprisingly, perhaps, there's been the most enormous amount of research conducted on the role that chemsex may play in facilitating STI or HIV transmission. I would say between about 2014 and 2019, probably 90% of the papers were studies looking at the association between those two practices, either via community surveys or more commonly through clinic-based studies and clinical audits. To be honest, they all say pretty much the same thing. They say there is an association, broadly speaking, between the use of drugs associated with chemsex and a higher risk of acquiring sexually transmitted infections, not necessarily HIV. And that's quite an important point to make. A few years ago, there were lots of claims about how chemsex was responsible for a big portion of HIV transmission cases that were occurring not just in Australia, but in other countries. There's actually limited evidence to suggest that's the case. It's more commonly the case that men who are already HIV positive are engaging in chemsex with other men who are also HIV positive. So where we're more concerned, I suppose, is around the high partner turnover and the longevity of sex, both of which are kind of prime breeding grounds for the transmission of particularly bacterial, but also other viral STIs rather than HIV specifically, particularly in a context like Australia, where we have a very high engagement and linkage into antiretroviral therapy and very, very high rates of people having an undetectable viral load. So the possibility for HIV transmission is actually exceptionally low in an Australian context, but it's STIs that we're most concerned about. These were just kind of two examples of studies that I pulled out, larger studies I pulled out that look at the associations between sexual health and the use of drugs. And as I say, they kind of talk, they nearly always say the same thing: a higher likelihood of having an STI diagnosis, more likely to have a high number of sexual partners. And interestingly, the AURA study reporting a much higher likelihood of having taken post-exposure prophylaxis in the past year as well. What lots of studies also document, particularly in the last couple of years, is a much higher proportion of men using a really strong association between engaging in chemsex and the use of PrEP, pre-exposure prophylaxis, which I suppose is quite a heartening thing to see, because at least it recognizes, it demonstrates that men who are at a high risk of acquiring HIV, given their partner turnover, are recognizing that risk, and they're taking steps to ameliorate it by the use of pre-exposure prophylaxis. And in fact, Mo Hamoud from the Kirby Institute wrote this great paper called The New MTV Generation, which was looking at the co-location of methamphetamine use for sexual arousal, Truvada for the elimination of HIV transmission, and Viagra, which facilitates sexual performance and can facilitate longer sexual encounters, particularly to counteract some of the effects, the impotent rating effect of crystal methamphetamine for some men. And looking at the co-location of these as an MTV practice. If you ever want to get a paper cited dozens of times, apparently all you need to do is give it a very catchy title like that, and Mo's done very well from that paper. It's a great paper, I recommend reading it. And so looks at this co-location of MTV for fun, sexual pleasure, and HIV prevention, and observes in that analysis certainly a notable and statistically significant uptick in that co-location of MTV, shown in the grey bar in 2017. And certainly a paper I think we're interested to rerun the analysis of that from Flux now in 2022 to see has that trend line continued in an upwards direction. And finally, my last couple of slides are broadly speaking around chemsex and harm reduction. One thing I think to be really mindful of, or to acknowledge as a really good thing, is the dense, that we're often talking about relatively small, but relatively dense and well-connected networks of men who are engaging in chemsex, particularly men living with diagnosed HIV. So there are ways to the opportunities for peer-based harm reduction approaches and peer-based education approaches for harm reduction, and through those networks, are actually quite considerable, because if we can identify and work with and train individuals who are part of these chemsex spheres around safe injection practices, around safe GHB dosing, for example, there's a potential to reach a relatively large proportion of the population. And there's experience and a history of doing that in relation to HIV prevention as well. So there's a lot we learned and have practiced for many years around peer-based HIV prevention, education, facilitating HIV testing for etc. So I guess I'm just saying there's strengths that we can draw on from within the communities that we're talking about here as a starting point for harm reduction. When we're thinking about the services that need to be established or developed or refined around chemsex, there's a few things to be mindful of. One is issues around treatment access. We have observed in several qualitative studies and actually in some of the Flux survey data that men are reporting that the drug use services, the services funded specifically in relation to drug use and harm reduction, are not necessarily always as familiar with the drugs that can be associated with chemsex. Perhaps a bit more so in relation to ketamine or to GHB than is the case for crystal methamphetamine, given its broader profile of use here in Australia. Not necessarily, those same services not necessarily always having a familiarity with the personal, social, and sexual contexts of use for this particular population, for men who have sex with men. Maybe this is the kind of talk that helps to address that particular issue and just educating and informing people around some of those cultural contexts and sexual contexts around how gay men are using these drugs for very specific purposes. And, it would be remiss not to acknowledge that there are some men who are reporting that they didn't feel that their sexuality was accepted or tolerated, or that people responded well to their disclosure of their sexuality within some drug services. And that will be more or less the case depending on which kinds of context you're working in, which city, which state. I'm in a rural or a regional area. It's an unfortunate truth that just has to be acknowledged and put on the table, and that there's always still work to do in reducing stigma that is associated with LGBTIQ communities more broadly. There's a key opportunity for service integration between harm reduction and drug services and sexual health clinics, given the co-location of drugs and sex. What can often happen in some contexts is that because it straddles both topics, it actually falls between the gaps of both, because no one service feels equipped or resourced to deal with the issue. So as a consequence, neither is picking it up and running with it to the extent that necessarily needs to be the case. I think there are some really great examples of where it is working well, but it isn't always the case, and something to be very mindful of. And of course, there's the opportunity for cross-training between sexual health and drug service staff. So sexual health staff can feel more confident and competent in engaging with issues around drug use, and vice versa. There's a really great resource around ChemSex and harm reduction by Harm Reduction International, an international NGO that speaks to these kinds of issues broadly. There are some good examples of harm reduction education resources available. One is the Thorn Harbour Health Touchbase website, which has a range of resources on it relating to safer drug use techniques and the things that you might want to consider when you're planning for having a ChemSex party, making sure that things like having a chart available for people to note down when they've taken GHB, doses of GHB, having little mini pipettes, micro pipettes available to ensure that people, if they're going to use G, can dose for it appropriately, having sharps bins available for used needles and syringes. They have toolkits for the monitoring of mental health and for people who might be exhibiting signs of particularly of psychosis if they've been a prolonged use of crystal methamphetamine and using it over a prolonged period of time. Toolkits for reducing use or managing use for those who want to kind of scale back their use, not necessarily to abstain, but to certainly just scale back their use, and explanations of the different kinds of treatment and support services that are available. So ranging from one-on-one counseling through to group therapeutic interventions in particular. Another really great website is the ACON's Pivot Point website, which has within it a lot of self-reflection resources. So encouraging people to just reflect upon, are they having the kinds of sex that they really want? Are they comfortable with the amount of drug use that they're having? When was the last time they were able or wanted to have sex without using drugs, often referred to as sober sex? So just encouraging some self-reflection, not to direct them down any one particular path, but a series of exercises of self-reflection. Some resources around mixing drugs and the safest means to manage drug use and the co-location of different drugs, understanding how to observe and detect the limits that you might have around drug use, safer injection drug use practices for those who do want to inject, recognizing and managing overdose, particularly important in the context of GHB use, as I was talking to, what are some of the things to be mindful and attentive to, and what would you need to do if you felt someone had overdosed. And finally, around sexual consent and assault. This is an issue that comes up repeatedly, I'm afraid, is people struggling often to navigate and work their way through the meaning of sexual consent in contexts where drugs are being used, where people can be cycling through a period where 1 minute they're riding a wave of euphoria, having taken crystal or G. It's the best sex they've ever had. They're enjoying, having group sex with 10 different guys, and that can change quite quickly for some people and fall off the other side of it. And suddenly you think I don't want to be here. I don't want to be in this context, and all that's happening to the person I'm having sex with, and quite how to navigate consent in those circumstances. And it's not uncommon within qualitative projects for participants to be reporting challenges that they've experienced in negotiating sexual consent. And so just kind of encouraging people to think through some of those issues and how and where to report safely if they feel that they've been the victim of sexual assault within a ChemSex environment. And there are a few, I would love to tell you that there's lots of published evidence of randomized control trials that speaks to different behavioral pharmacological interventions to introduce in the context of ChemSex. That's simply not the case. The literature isn't quite at that point yet. We started out in about 2014 and 15 qualitatively describing the phenomenon. We spent the next few years looking broadly at the prevalence and patterns of chemsex. We're seeing more case descriptions of services and interventions now, and some small scale evaluations, before and after evaluations of them. We simply haven't got to the point yet where there's been large scale behavioral interventions that have been where there's been sufficient definition, size, and scope and resourcing for for the development of control trials, for example. So that just isn't a literature I can point you to yet. But here are some examples of therapeutic approaches where there have been published in the academic literature, that broadly, I think in every instance actually talks about before and after evaluations of people engaging in therapeutic interventions. And that, I think, brings me to the end. Because I'm involved in Futures I'm in Flux, I just wanted to acknowledge all of my colleagues who work on and lead those projects, and particularly Jen Power, Garrett Prestige, and Mo Hamoud, who are all absolutely fabulous people, and the funders of those studies, and particularly the ARC and the Commonwealth Departments, Department of Health for Futures, and GCPS. And Chris, I think I'm going to leave it there, if that's all right.
No, thank you, Adam. Very rich and thought-provoking presentation. I'm going to ask everybody, if you've got questions, to please put those into our chat or Q&A areas. While we're doing that, you mentioned there's not yet randomized control trials and so forth. Strikes me as the sort of thing that's hard to do, a randomized control trial. What are you hoping to randomly control?
Oh God, I don't know. That was probably a slightly flippant way of describing it there. No, I mean, I can't really imagine an RCT in this context, to be honest. I think what's just missing, but there's so many things we haven't yet refined. We haven't really reached consensus around case definition, around the drugs that we consider part of the chemsex sphere, around the time intervals that are most appropriate. We're missing those event level data to power those kinds of analyses. Like it's really hard to get to the point of thinking of intervention evaluation when they're so near the formative things to control for in the meantime. I mean, Krista is leading with Jack at ACON and the Kirby a really innovative, I think, peer-based approach to drug use among LGBT communities, and particularly GHB. And oh God, if Krista's online, I mean, she might be able to speak to some of the ins and outs of that evaluation, that intervention, development, evaluation process. But I guess, yeah, I was just trying to make the broad point that I don't have a single solution to point everyone to here. There's a range of education and therapeutic approaches which are showing merit, but we're away from saying, here's a definitive list of interventions that have been tried and tested, and we really want to direct people towards utilizing.
Yeah, so Jack's project, looking at a brief intervention delivered by peers, will be an interesting one to watch. He's just been he's just finalized inducting all of the peers to deliver that service, and he's starting to enroll participants, and there'll be a qualitative as well as a quantitative component to that study. So definitely, I think Adam's right. There is still an opportunity to look at different methods of getting harm reduction knowledge out there, different methods of encouraging people to take it up, and different ways of supporting people who, I mean, that's quite a high proportion, that 15% who think that they identify their drug use as problematic. So there's still question about how we reach those people and what we can offer them in a space and time that feels comfortable for them, I guess.
Yeah, absolutely.
So I mean, and I have to apologize, I did drop out for about 2 minutes there while you were talking about harm reduction strategies. I imagine for the clinicians on the line, so obviously we've got a wide mix of people online here. For the clinicians that work, seeing patients in, say, hospital settings or referred from wherever, most of the management at this stage is going to be geared towards harm reduction in the form of appropriate, making sure there's appropriate checks for STIs, PrEP where it's required, and those sorts of things. Would that be fair to say?
That would be entirely fair to say, and referrals on where necessary, appropriate for a kind of focused mental health support, particularly for those, that small proportion of men utilizing crystal meth for whom psychoses can become a particular concern, and so that's yeah, and then harm reduction education around safe dosing is the kind of key things to be attentive to. And direction to, as a clinician, direction to people like ACON or Thorn Harbour for those therapeutic group work interventions, one-on-one counselling interventions specifically focused on ChemSex would be the kind of fifth dimension I would be holding in mind as a clinician.
Putting on my tox hat for a moment, we still do get one or two people who drink the amyl.
Oh my God, yeah.
Oops.
Oops, yeah.
Sniff it, for God's sakes, if you're going to use amyl out there. Yeah, so please, if anybody's got any questions, please do pop them in the chat.
I'm curious, I realize that we're running really close to time, so I apologize for putting this out there now. But I'm just curious, I've just had a quick Google and I don't find a lot. And I'm just curious if there's any data, Adam, on the impacts on arousal amongst women who consume some of those same drugs. I can find data on rats here. I can tell you about some rats, but I'm just curious if there's anything more widespread out there that you want to comment on or could comment on.
Yeah, God, I wish I could say yes, that I knew of things, and I keep thinking this literature's been running for such a long time. Surely someone's been exploring and publishing on this. I'm yet to see it. That doesn't mean it's not there. I'm very much an LGBT focused researcher, so it's not the kind of area I would necessarily enter into, but it just seems so ripe for exploration. And it's not like gay men are the only people in Australia who use crystal methamphetamine. So, surely there must be reports of sexual arousal among women as well. But yeah, sorry, Krista, I don't have the answer to that, but it must exist, I'm sure.
Yeah, it's just an interesting, I guess, point to make. And
yeah, totally.
Definitely. That's I didn't pick up on that. Well done, Krista.
Oh, well, I mean, writing about women's pleasure, maybe that's the problem. Not a popular topic to publish on. Women,
not allowed to.
Women enjoying sex. Wow.
That sounds outrageous, Krista.
Absolutely outrageous.
No, you're probably right. I hate to admit it. You're probably right. It hasn't been for any number of structural, horrendous, misogynistic reasons. I think there's probably some truth in why that hasn't received sufficient attention.
There we go. The next project for someone who's online. Let's chat.
Well, I think that might be all we've got. That's always a sign that you've covered the topic incredibly well. So, which is great. So if you don't mind, it's 3:30 now. We might call it a day. But thank you, Dr. Adam Bourne, and much for your presentation. And for those online, look forward to seeing you next week. And please, if you want to look back on any of the recordings that we've got, they're all available on the NCCRED website as well. But thanks again, Dr. Bourne, for your presentation today.
No problem. Thanks for having me.
See you later.